Hi there, I'm a Psych NP and I have 25 questions for you on early onset schizophrenia. Ready? Let's learn psych fast. Question 1. What distinguishes childhood onset schizophrenia from adolescent onset schizophrenia in terms of course and symptoms? Is it A, childhood onset schizophrenia has more acute course and fewer cognitive consequences? B, childhood onset schizophrenia has a more chronic course and increased negative symptoms? C, adolescent onset schizophrenia has a more chronic course and increased positive symptoms? Or D, adolescent onset schizophrenia has a more acute course and fewer cognitive consequences? The answer is B. Childhood onset schizophrenia has a more chronic course and increased negative symptoms. So childhood onset schizophrenia is described as a rare and virulent form and a progressive neurodevelopment disorder. It has a more chronic course compared to adult onset schizophrenia. It leads to a severe social and cognitive consequences and increased negative symptoms. In contrast, early onset schizophrenia, which includes both childhood and adolescent, is associated with a severe clinical course, poor psychosocial function, and increased severity of brain abnormalities. Childhood onset schizophrenia is described as having a more persistent and prolonged progression of the disorder, thus chronic. There are also increased negative symptoms that are more prominent in childhood onset schizophrenia compared to adult onset. These are symptoms of increased negative symptoms, which include emotional flatness, lack of motivation, and social withdrawal. A was incorrect because childhood onset schizophrenia is described as chronic, not acute, and it has a more severe cognitive consequence. C is incorrect as it's negative symptoms, not positive symptoms like hallucinations or delusions for childhood onset schizophrenia. And D, that's incorrect because the course is chronic and the cognitive consequences are severe, not fewer. Question 2. Which of the following is a characteristic of childhood onset schizophrenia? A, onset is psychotic symptoms after 18 years of age. B, lower rates of heritable etiology compared to adult onset schizophrenia. C, evidence of widespread abnormalities in the development of brain structures. Or D, less severe social and cognitive consequences compared to adult onset schizophrenia. The answer is C, evidence of widespread abnormalities in the development of brain structures. There are specific characteristics of childhood onset schizophrenia that emphasize the severity and distinct features compared to other forms. And these are such as the childhood onset schizophrenia is a rare and virulent form of schizophrenia, and it's now recognized as progressive neurodevelopment disorder. Evidence of widespread abnormalities in the development of brain structures include the cerebral cortex, white matter, hippocampus, and cerebellum. Severe social and cognitive consequences and increased negative symptoms are mentioned in relation to childhood onset schizophrenia. Question 3. Which cognitive measures are particularly impaired in children with childhood onset schizophrenia compared to those of adolescent onset schizophrenia? Is it A, verbal communication and social interaction? B, IQ, work and memory and perceptual motor skills? C, emotional regulation, impulse control, or D, academic performance and creativity? The answer is B, IQ, work and memory, and perceptual motor skills. So children with childhood onset schizophrenia have a more significant deficits in measures of IQ, memory, and tests of perceptual motor skills compared with adolescent onset schizophrenia. These impairments might be premorbid markers of illness rather than sequelae of the disorder. Question 4. What is one key difference in the clinical presentation of childhood onset schizophrenia compared to schizophrenia in adolescents and adults? A, childhood onset schizophrenia lacks cognitive impairment. B, childhood onset has a unique set of positive symptoms. C. Failure to achieve expected social and academic functioning replaces a deterioration in functioning. Or D. Childhood onset schizophrenia always leads to complete social withdrawal. The answer is C. Failure to achieve expected social and academic functioning replaces a deterioration in functioning. Question 5. Which of the following is more likely to be present in youth with schizophrenia compared to those with adult-onset schizophrenia? Is it A. Auditory hallucinations, B. Blunted affect, C. Premorbid history of social rejection, or D. Persecutory delusions? The answer is C. Premorbid history of social rejection. So youth with schizophrenia are more likely to have a history of social rejection, poor peer relationships, clingy withdrawn behavior, and academic trouble compared to those with adult-onset schizophrenia. Question 6. Which symptom is commonly observed in children with schizophrenia and is often associated with a lower IQ and earlier age at onset? Is it A. Auditory hallucinations, B. Visual hallucinations, C. Delusions, or D. Blunted affect? The answer is B. Visual hallucinations. They are associated with lower IQ and earlier age of onset of the disease in children with schizophrenia. Actually, the National Institute of Mental Health study found high rates of tactile, olfactory, and visual hallucinations among children with childhood-onset schizophrenia. Question 7. What symptoms appear almost universally in children with schizophrenia? Is it A. Grandiose delusions, B. Command hallucinations, C. Blunted or inappropriate affect, or D. Visual hallucinations? The answer is C. Blunted or inappropriate affect. This appears almost universally in children with schizophrenia. Children with schizophrenia may giggle inappropriately or cry without being able to explain why. Question 8. Which statement is true regarding delusions in children with schizophrenia? A. Delusions decrease in frequency with increased age. B. Young children's delusions often involve age-appropriate content like animal imagery. C. Delusions are more complex in younger children than in older children. Or D. Delusions are rarely observed in children with schizophrenia. The answer is B. Young children's delusions often involve age-appropriate content like animal imagery. And this imagery might be of monsters, animals, just delusions that increase in complexity as they age. Delusions occur in up to half of children and adolescents with schizophrenia in various forms, including persecutory, grandiose, and religious. Delusions increase in frequency with increased age. The delusions of young children, though, are less complex, describing them like imaginary animals and monsters, and that's likely to be the source of delusions of fear in children that are young. Question 9. According to DSM-5, what might a child with schizophrenia experience regarding their level of functioning? Is it A. Complete recovery and normal functioning, B. Stable function without any deterioration, C. Deterioration of function or failure to achieve the expected level of function, or D. Improvement in academic performance and peer relationships? The answer is C. Deterioration of function or failure to achieve the expected level of functioning. The DSM-5 notes that a child with schizophrenia may either experience deterioration of function or may never achieve the expected level of functioning. Question 10. Which of the following is a significant predictor of the course of and outcome of childhood and early onset schizophrenia? Is it A. Child's age at the first psychotic episode, B. Level of family support, C. Response to psychosocial and pharmacologic interventions, or D. All of the above? The answer is D. All of the above. Question 11. Which factor is known to influence the relapse rate in adults with schizophrenia and likely affect children with childhood onset schizophrenia? Is it A. The degree of family support, B. Family history of bipolar disorder. C. High expression of negative emotion, EE. Or D. Response to antipsychotic medications. The answer is C. High expression of negative emotions. So, high expression of negative emotions, EE, is known to influence the relapse rate in adults and likely affects children with childhood-onset schizophrenia. Question 12. Which comorbid condition is associated with a less favorable prognosis in children with early-onset schizophrenia? Is it A. High IQ, B. Developmental delays, C. Absence of premorbid behavioral disorders, or D. Low family stress? The answer is B. Developmental delays. So, children with comorbid developmental delays and lower IQ are less treatment responsive and have a more guarded prognosis. Question 13. How do children with childhood onset schizophrenia typically respond to antipsychotic medications compared to adolescents and adults? A. They have a more robust response. B. They have a less robust response. C. Their response is the same as adults. Or D. They do not respond at all. The answer is B. They have a less robust response to antipsychotic medications than adolescents and adults. Question 14. Why is monitoring the educational setting important for children with childhood onset schizophrenia? A. Because they excel academically and need advanced programs. B. Due to frequent social deficits, attention deficits, and academic difficulties. C. To ensure that they are isolated from others, students. Or D. Because they do not benefit from a structured educational environment. The answer is B. Due to frequent social skill deficits, attention deficits, and academic difficulties. Question 15. What is the primary pharmacologic treatment for schizophrenia in children and adolescents? Is it A. First-generation antipsychotics, B. Selective serotonin reuptake inhibitors, C. Second-generation antipsychotics, or D. Tricyclic antidepressants? The answer is C. Second-generation antipsychotics. Why is that? Well, they're the mainstay pharmacological treatment for children and adolescents with schizophrenia. These medications include risperidone, olanzapine, aripiprazole, and clozapine. Question 16. Which antipsychotic medication is considered a choice of last resort in youth due to its side effects? Is it A. Risperidone, B. Olanzapine, C. Aripiprazole, or D. Clozapine? The answer is D. Clozapine. So clozapine, despite being effective in reducing positive and negative symptoms, it is considered a choice of last resort in youth due to its side effects, which include lipid abnormalities and seizures. Question 17. Which psychosocial interventions are critical components of the treatment plan for childhood onset schizophrenia? A. Play therapy and art therapy. B. Psychoeducation and family therapy. C. Music therapy and dance therapy. Or D. Biofeedback therapy and hypnotherapy. The answer is B. Psychoeducation and family therapy. So, family education and patient and family support are critical components for the treatment plan for childhood onset schizophrenia. Making option B the correct answer. Question 18. Which psychosocial intervention has been shown to lead to improved clinical symptoms in young adults with the first episode of schizophrenia? Is it A. CBT, B. Music therapy, C. Play therapy, or D. Art therapy? The answer is A. CBT, cognitive behavioral therapy. Question 19. What side effects are commonly associated with risperidone in children and adolescents? Is it A. Weight gain and dystonic reactions, B. Lipid abnormalities and seizures, C. Moderate sedation and significant weight gain, or D. Extrapyramidal adverse effects and weight gain? The answer is D. Extrapyramidal adverse effects and weight gain. So risperidone can cause weight gain and dystonic reactions and other extrapyramidal adverse effects in children and adolescents. Question 20. What is the estimated prevalence of childhood-onset schizophrenia compared to adolescents? A. Less than 1 in 40,000 children, at least 50-fold increase in adolescents. B. Less than 1 in 10,000 children, and at least 100-fold increase in adolescents. C. 1 in 1,000 children, and at least 10-fold increase in adolescents. Or D. 1 in 100 children, and at least 5-fold increase in adolescents. The answer is A. Less than 1 in 140,000 children, and at least 50-fold increase in adolescents. Question 21. Which comorbid disorder are commonly associated with childhood-onset schizophrenia? A. Bipolar and obsessive compulsive disorder. B. Autism spectrum disorder and conduct disorder. C. ADHD and depressive disorder. Or D. Schizoaffective disorder and borderline personality disorder. The answer is C. ADHD and depressive disorders. Question 22. What is the estimated ratio of boys to girls diagnosed with childhood-onset schizophrenia? A. 1.67 boys to 1 girl. B. 2 boys to 1 girl. C. 1 girl to 1 boy. Or D. 1.5 boys to 1 girl. The answer is A. 1.67 boys to 1 girl. Question 23. What is the prevalence of schizophrenia among parents of children with schizophrenia compared to patients with adult-onset schizophrenia? A. About 8%, half the prevalence in parents of patients with adult-onset schizophrenia. About 8%, twice the prevalence in the parents of patients with adult-onset schizophrenia. About 4% and half the prevalence in the parents of patients with adult-onset schizophrenia. Or is it D, about 4%, twice the prevalence in parents of patients with adult-onset schizophrenia? The answer is B, about 8%, twice the prevalence in the parents of patients with adult-onset schizophrenia. Question 24. What is the estimated heritability of childhood-onset schizophrenia? Is it A, 50%, B, 70%, C, 80%, or D, 90%? The answer is C, 80%. Question 25. What is suggested to be a significant contributing factor in the psychotic symptoms and cognitive deficits in childhood-onset schizophrenia? A. Abnormal early brain development. B. Environmental toxins. C. Lack of social support. Or D. Dietary factors. Answer A. Abnormal early brain development. All right, all done. Hope you found this helpful. If so, please share it with one of your classmates.